from EASD, brought to you by Diabetes India in association with all the sponsors for the event. Today, we're focusing more on type 1 diabetes. So, what we have is we have two talks today. One by Dr. Archana Shraddha will be talking about what are the strategies which we have in our part of the world to deal with type 1 diabetes, and then followed by Dr. Bansi, who will be talking on hypo and decay in type 1 diabetes. It's a recorded talk. Please bear with us. He's traveling. And then we have a panel discussion moderated by Dr. Brij Mohan on the same topics. Over to Dr. Archana Shraddha for her talk, and then Amit will take over. Thank you. I'm there. I'm hanging out to listen to your talk. Right.
Thank you so much, Dr. Thank you, Dr. Sanjay, and thank you everyone for joining in. And we are now going to talk about a very less talked about topic, and that is disparity and what are the strategies when it comes to taking care across the globe. So just let me share my slides. Just give me a second. Yes. Is that visible? The slides are visible? Are they full screen?
Yes, madam, you're very visible and
yes,
all.
Wonderful. So the topic is strategies to reduce disparities in pediatric type 1 diabetes worldwide. Although this was the topic which was presented by Dr. Thomas Ted in the Diabetes India Symposium of EASD. And although the topic is type 1 diabetes worldwide, the emphasis was that where does India stand in this worldwide disparity. So we know there are disparities. We know there is lack of equality, equity, all those factors are there. But what can we do about it? So my disclaimer is there's no conflict of interest, but I would be lacking if I did not thank Dr. Thomas Ted, because many of the slides here are from the Breakthrough Type 1, which we knew as JDRF earlier, and are his slides, which were there when we attended the talk and listened to his thoughts. So what is really very important to understand that most of the global T1D population does not have access to the T1D therapies and care. And this is a very alarming slide, and it is from Breakthrough T1D, and this data is theirs. And the level of care, if you see a cure, currently we know that none of us in the world have access to it, but advanced care, which we talk about so much, most of our conferences, tech-led conferences, major conferences, we are talking about device-led, for example, AID systems, we're talking about CGMS, we're talking about all kinds of therapies based on tech, but it is only 10% of the global population that has access to these therapies. And then we talk about some comprehensive therapy. But even the comprehensive therapy, which would mean analog basal boluses, plus minus could be with pumps or without pumps, more than 5 tests a day or CGMS. Now, to a logical mind for a person living with type 1 diabetes or as a doctor prescribing treatment for type 1 diabetes would think that analog basal bolus and 5 tests a day or analog basal bolus and a CGMS would be like a basic standard of care, but that's just available to 20% of the people living with type 1 diabetes across the world. Again, intermediate care, which would be human insulin, but would have a basal insulin, which would probably be glargine, analog glargine, because we're not talking about using NPH there, but we would limit the test to 2 to 4 with no access to CGM. That's 30%, and probably that's an improvement for what was there last 10 years back. But minimal care, which is still human insulin, unfortunately still twice a day, and just 1 or 2 tests or none, is 30% of the population. And no care, unfortunately, is still across the globe 10 to 15% of the population. So this slide really opens up the eyes and sees what a spectrum it is. And in that pyramid, how narrow is the top, where even comprehensive care, we're not even talking about advanced care, is available. And if we go on to think about it in India, then we don't have actual data, but we know that this would become even narrower at the top when it comes to Indian statistics. So Dr. Thomas Dante presented there that if we really need numbers to advocate for change. So we have huge numbers. T20 index has been working in this. And if we have these numbers across the world, look at that spread across the world, where there is intensity, there's density of people living with type 1 diabetes. And that is 1.5 million children and adolescents. And we're talking about only between 0 to 19 years that are living with type 1 diabetes globally. And over a million of them, that is 2/3 of them, live in the middle and low income. So we can see the access of care that we were talking about, where they would match. Again, incidence is rising by 3.5% per annum. That is 200,000 new cases are being diagnosed every year globally between this age group. I think all of us must be seeing that, and we are all wondering whether it is because they're surviving or they're getting diagnosed, or it is an actual incidence which is increasing, and all of us are seeing this in their own clinics. I see at least 5 to 8 newly diagnosed children living with type 1 diabetes every month for the last few years, which was not there earlier. So thus that fact, the way it is increasing, it tells us that we can't really not look at this issue. Again, if we look at from a global to an Indian perspective, we are sadly home to the world's largest number of children and adolescents living with type 1 diabetes because of sheer population. Maybe as a percentage, our numbers may be low, but the sheer population is so big that even that is still the global largest number. Out of the 8.6 that has been stipulated to be approximate number in India, it is around 3 lakh children, 300,000 children who are below the age of 19. But this number should have been really higher, suggesting that there would have been a much, much bigger number if they had standard of care, if even the basic care had been available, if we could have gone to level 1 or level 2. And hence, these two numbers together make us India as a global capital for type 1 diabetes by quite a big margin. If you see next number, the ones that we don't know and the ones that we know. Having said that, we don't have a registry, we don't have numbers. These are all coming from the estimated numbers, especially from the type 1 diabetes index, which uses a computed formula in a way to work out how many children we would have. But imagine by 2040, there will be 6 million lost lives due to lack of access type 1 diabetes. So these topics become really, really touching to everyone, relevant to everyone, which otherwise feels like a niche topic, but yet today needs to be talked at every conference, every platform, because these numbers are increasing. And this is something which is just not unacceptable, which is not acceptable. Now, although we're talking about the world, but it's very important, and even there in EASD, the focus was, say, India and its sort of relationship to the world scenario. So in India, as per the type 1 diabetes index, and that term along with the IDF data, life expectancy for a person living with type 1 diabetes is only 34 years. I think this is a very, very important information that we have to talk about, which is driven mainly by the limited access and availability of standardized care in type 1 diabetes. So just imagine that if a person, if you look at this, if you look at the distribution by each country and you look at the life expectancy here, and we have around 8.6 lakh people living with type 1 diabetes, which is 10% of the global disease burden. Right? In our country, we are growing at 6.7%. And while type 2 is growing by 4.4%, 4.4%. So if you see the proportion at which we are growing, the numbers we are, 10% of the global population, yet our life expectancy is just 34 years. Look at the slide on this right side. And average life expectancy is much lower than even other lower and middle income group countries. It is not only about when you compare it with the UK and you compare it with USA. If you look at the others, look at China, Brazil, Morocco, Sri Lanka, we are even worse there. In India, we are at 34. So this is sad. And that is a 45 years of life, healthy years, which are lost by a person living with type 1 diabetes. And this is all based on the type 1 diabetes index. But I think if we think about it, it can relate very well to what we see, because when we look at how many people are still living with type 1 diabetes who have crossed, say, 50 years of type 1 diabetes. There are many. We have 80s and 70s also, but that's still a handful. These are people who could access care at that time, who were well-to-do or educated or made an effort, had a guidance. Otherwise, it's not happening. So why does India look like this? And this is definitely an eye-opener when you compare it to the world. And in spite of we are a rich country, we have a rocket on the moon, we have rockets everywhere, we spaceships, we are no longer a lower middle income group, yes, because we have many Indias in India, but we also have lots of prosperity and industry and everything. Then why does India look like this? Because look at these numbers. 10% is just shorter life because of no care and no diagnosis. Then it is rationed, pre-mixed few tests, that's 28% of them. 54, if you see, is the of this is insulin strips and self-management, and 60%, if you want, you could give it to pump, CGM, and self-management. If at all, and that's just 1%, 10% of the cases are on the 54 life expectancy that we could have had, and 80% are on this 28 life expectancy, and 10% sadly are actually dying. So if this is the situation in India, and this is the situation I'm sure we all know, then there is something we need to do about it. So I'm going to have a small perspective of what is happening in India to change this disparity and what is happening at a global level to change this disparity. So one of the things that we have realized, these are a few of my little ones who are in Udan, and when I look at them, and they were diagnosed early. Some of them were actually diagnosed without DKA because their mothers were aware and because they had heard, read. So if we can diagnose early to save lives, that would be one big step to avoid disparity. So even simple teaching like this is one of the teaching material created by CHAI, the Clinton Health Foundation, which is going with the National Health Mission to different states. And it is for free use. You can download it and you can reuse it anywhere. But just knowing the signs and symptoms, understanding what is type 1 and what is type 2, as basic as that, and detecting it. If this could happen at Anganwadi level, if this could happen at school level. So this is one thing which is being tried, which is one level at which it is being worked, detecting early to avoid decay. And then, of course, goes the next step. Now, what are these primary problems when it comes to India? These are the possible challenges. So because our care is primary, concentrated, tertiary center and very specific geographies, so limited access, barrier to care, what is happening at pre-diagnosis level? Low awareness, delay in decision to seek care. At diagnosis level, misdiagnosis and unwilling to initiate insulin treatment, not only from the patient's perspective, but also the caregiver and also the HCP who is not yet trained, who's not aware or capable. Initial treatment and management, availability of specialists, limited capacity, understanding the management. So the easiest thing is put them on a premix and let them go. So to be treating them like type 2s is something that happens. Again, availability, affordability, monitoring, delaying in initiating treatment, hospitalization. Then at living with diabetes level, basic accommodations that is needed, discrimination which is not, stigma which has to be addressed, counseling, knowledge, self-management. So all these things are at every step, there is a barrier currently in Indian scenario. So strengthening this care at a public health level, which is many programs now. So India is at a good stage that way, in the sense a lot of things have been initiated. We are not there, but at least we have woken up, we are doing something. So standardized guidelines and protocols are being created. Building service provider capacity is the second level where various organizations are working upon, and improving access to commodities and drug is the third focus, and strengthening the follow-up, the referral structure is the last, and education and support, where we are talking about not just people living with diabetes and caregivers, but also the community, because the type 1 community is a very strong part. What needs to be taught to them is that we all know this, but some basic protocols. We are no longer looking at basic care. Basic care, we were talking about 2 strips or not checking. That's not okay. And what's the point in giving something substandard? Once we ask for something substandard, it'll take another 50 years to upgrade it. So at the very first level, we want to try for at least comprehensive care. And hence basal bolus self-monitoring adequately, counseling, education, follow-up, and screening for complication is a must. And that is what at the government level, at the public health level is being happened. So now these are some programs in India which are happening with the governments of different state, with the Clinton Health Foundation is en route making it happen, and these are being funded by Breakthrough Type 1 Diabetes. So that is something that Dr. Thomas Dan shared. I'm happy to say that I've been part of the training programs in these states, and we found very good enthusiasm. The program at Madhya Pradesh is already on. Rajasthan received it very well. Next two are now ongoing. But when the National Health Mission and public health and organizations like JDR are coming, then at least at a basic level, community engagement, clinician network, and government collaboration is happening. And if these are successful models, then hopefully every state will take it forward and this should become successful program. So these are first steps, baby steps, but we are hoping that this is going to work. Now, why does it always need somebody to come in and do it? But I think India is now, there is hope. Like few years back, there would have been nothing to say except wailing with problems on this top. But today, we have organizations like RSSDI, which runs a dedicated program for type 1 diabetes. Life for a Child is supporting at least 15 centers in the country with access to basic amenities, basal insulin, as well as glucometer and strips. CDIC is supporting a large number of children across the country. ISPE is running educational programs like IDEAL. Clinton Health Foundation is collaborating with Breakthrough Type 1 Diabetes and governments of India. PPHF is running a very dedicated type 1 advocacy and livelihood and working on a project with the government of India. West Bengal government has a very interesting model which was created by Dr. Sujoy, and that is now implemented to many district hospitals. There are more than 40 type 1 foundations. There are many, but more than 40 are very, very vocal, active, and they're working in their own areas, taking care, providing, reaching out to large number of people in the areas who are underprivileged, supporting, motivating, educating them in many ways. Tie-up is was the first type 1 diabetes conclave that started last year, and now it is a national program. Empower T1D is a type 1 group. So all these groups are working relentlessly in India. All of them have a common goal, but they are working in their own ways with their own ideas. At least at heart of everyone is reducing the disparity, this loss of life that we are talking about, 47 years lost, average life of being 35, that has to change. Comprehensive care has to happen. This was what Dr. Thomas Dan presented there. And at a global level, it is ISPAD, the SWEET registry, the SWEET, and the Breakthrough T1D. So all three together are working at a global level in a very, very structured manner. So they have a very robust vision. They have been doing it for last 50 years. So they have a planning, data collection, analysis, setting targets, and action and monitoring. I think as Indians, and I'm being very candid here, this is something we lack in India. We do not have our own registry. We do not have a roadmap yet for the entire nation. We don't even have a problem statement, which is ours own. We are just taking things which have been told to us, the idea, the T1D index. So we yet need to work on our own problems and have a proper pathway, a roadmap ready. But just to name see how it was done. The SWEET registry in 10 years has been in 19 countries. In India, I think Dr. Banshi Sabu was instrumental in bringing his SPAD and SWEET registry to India. And since then, India has, I think, 15 centers, and there is a very good benchmarking, good practices are shared. And that showed, though the numbers kept on increasing, what it really showed was association of improved HbA1cs in 21 of the 22 international pediatric centers. One of the slides he showed, which I could not find, is also that the Indian centers did not show that much of improvement as compared to global. So there is something missing. Maybe it is a social aspect, maybe it is a stigma, but something is missing. But across the world, the SWEET registry was able to optimize care and outcomes for children across the globe. And you can see as the numbers have been increasing over the years, and again, that number is growing day by day. Number all countries, including in India. As you can see, there are so many centers in the map from India as well. So I think I don't have much more to say because we don't have Indian data. I wish we did. And of course, we are very conscious that we need a national registry. A very broad level, high level thing that I'm talking about. We know we have hundreds of things that we need to do, but very, very high level thought, we need a national registry. We need to implement the NCD program for juvenile diabetes. A good thing is that with the effort of everyone working in the space, finally the government this year has juvenile diabetes. They've called it juvenile diabetes so that they can include it in the pediatric group in the NCD program. So now that the NCD program has juvenile diabetes, we are hoping it will go to the school health program. It will go to the last mile. It will involve availability of training, availability of medicine, and everything else. Of course, we need a roadmap for comprehensive care, which I feel very sad when I see the global thought process and it is not. And I would like to end that, yes, we are there. We are working on it. We have reached somewhere, or I can say we have started. So to quote Swami Vivekananda, that arise, awake, and stop not till the goal is achieved. So I think the path is really, really, really long. It's going to be tough, but every life matters, every step we take, and to reduce the disparity, to improve one level of care in one child, all will add up to give us a great result. These are some of our children who are from the real villages, very low resource setting, and today they are flaunting their CGMS. So from being daily wage workers to be able to today flaunt and be happy with their CGMS, they do a EMI, they take a smartphone, they're able to now scan, and they do use it intermittently, but they're able to do some kind of carb counting, adjust their doses, use calculators. So it's possible, and that is a dream I would like to share, and that is something we would like to do for India. Thank you so much.
Thank, thank you, Dr. Archana, for your comprehensive talk. And we will now play the talk of Dr. Bansi Sabu. And then we will, Dr. Brij Mohan will initiate the panel discussion. So I will request RX team to play the slides of Dr. Bansi Sabu, please.
that.
Hello, dear friends. I am Dr. Bansi Sabu, currently Chair-elect of International Diabetic Federation Southeast Asia. Today, I am going to talk on a primary to primordial prevention of diabetes in India. This topic we have decided that in India, primary prevention, we have done one study, but still, if we really want something primordially prevent diabetes in our country, then we have to do something more. Just not for the people who are already at higher risk of developing diabetes, and then we try to prevent the diabetes. Rather, we have to do for the normal persons to become diabetes, or they should not become at a higher risk of developing diabetes. I'm thanking Diabetes India for giving me this opportunity, for this wonderful platform where we will be talking learnings from EASD. And I had given the same talk in our Diabetes Asia Study Group DSG Symposia in EASD. I have nothing to declare. We all know that this is a dreaded disease which is shaking our foundation. In India at present, we have 101 million people with diabetes, and this incidence is increasing continuously. Globally, it is 45%, but in India, unluckily, it is 123% increase in our country. As I told you, if you really want to primordially prevent diabetes, then we have to intervene very early to prevent diabetes. This is the number which we must have seen multiple times in different presentation. But this shows that in Southeast Asia, when primarily it's an Indian subcontinent, the number of people who are becoming diabetes are very high. You can compare it with European population where it is 13%, while it is 68% in our population. This rising prevalence data is showing that in India in 2023 publication by ICMR in diabetes study, we have 101 million people with diabetes. But what is more worrisome is we have 136 million people with pre-diabetes and we have 351 million people with abdominal obesity. It means the number of people with diabetes are going to increase in our country day by day. With other risk factor of cardiovascular disease like dyslipidemia and dysglycemia and hypertension, which is also very, very high in our country. The prevalence of people with diabetes by age and income group, if I see, it is the problem that we have a diabetes which is very high in 40s or 50s in compared to other developed countries, while we are also worrying of this fact that we are developing diabetes even in late 20s. So that's again a problem that we are developing diabetes very early in the course of disease, that those who are developing in their 20s or 30s, they are going to live for another 30, 40 years with a lot of complications. One more challenging issue is that we also have hyperglycemia in pregnancy, highest in compared to other parts of the world. So, I mean, this is again one more challenging aspect of diabetes in our country. So today I can say that India is suffering from, or a Southeast Asia is suffering from as a developing countries, not influenza, but rather affluenza. We are becoming more affluent, that is increasing calorie intake while decreasing physical activity, which is responsible for increasing diabetes in our country. When we want to prevent diabetes, we have to prevent at every stage. And that is what we can think of primordially preventing diabetes. While at present we are working only at the accumulated risk when someone is already having multiple risk factors of developing diabetes, and then we start intervening these people, they are in their adult age. While we have to work at fetal life, at infancy, at adolescence also, and that is what we have to do if we really want to primordially prevent diabetes. So it means there is a possibility of prevention of diabetes at every stage. Actually, primordial prevention is that stage which should not have come, which is responsible for someone to develop diabetes. And this is what we want to do, a primordial prevention, not just primary prevention. Otherwise, this incidence, as newer and newer persons who are coming in this stage of pre-diabetes and diabetes or dysglycemia, we will never able to decrease the incidence or overall prevalence of diabetes in our country. There is one more interesting fact which we have. If you see the world map, you will find that in India or India subcontinent, we are the one who have the lowest birth weight in the world. So in compared to the Western Europe or in compared to any part of the world, we are having the lowest birth weight which we have. It means average birth weight of our child is around 2.8 to 2.9 kg, while the developed world or the Western world, they have birth weight of around 3.2 or 3.3 kg. So we are actually capital of two. One side, we have undernourished, low birth weight children, which are highest in the world. And we also have the people with highest number of people with diabetes in our country. So, I mean, these are the two conditions which are completely, one say, contradicting each other, but still we are having the capital of these two problems which are there in our country. It means there is some correlation with this, the underweight and a low birth weight children having higher risk of developing diabetes in adulthood. To explain it more, this is the paper which is published by Yagnik in 2002, which is talking about small, thin, fat Indian baby. So a baby which is born in India having actually low birth weight, but still the fat percentage of that baby is high. I mean, a 2.5 or 2.8 kg birth weight baby having more than 25% fat in his or her body, while a white Caucasian child is having fat percentage of 3.2 average birth weight, while the fat percentage of the child is around 15%. So there is a significant difference. They are small size, more fat, less muscle mass, less viscera, high insulin, high leptin, and low adiponectin, which we have. And what happens in an Indian scenario? The complete family starts feeding the child. The family starts making this child who is low birth weight, trying to increase his fat, trying to increase his weight, and that increase is continued till his adolescence and early adulthood, which is responsible reason for them to develop diabetes and other cardiovascular disease risk factors too. So we are not only thin fat Indian by birth, but also in adulthood. We are one whose muscle mass is less, while fat percentage, the visceral fat is high. We develop diabetes at a lesser BMI. We develop diabetes almost 10 or 15 years younger. And this one more paper nicely published by Dr. Yagnik in 2004, immediately after which he had shown thin fat babies. He had shown that his fat percentage is 21.2. Even he looks lean and thin, while Professor Yudkin, who is colleague, who is a British guy, with the fat percentage of 9.1. So you can see a significant difference in fat percentage between a persons like Yagnik and Professor Yudkin. It is because of the fat percentage in Indian people is higher with a BMI of 22.3, which is an ideal BMI. And this makes that we are lean, we look thin, but still we are fat. And that's what the concept of thin fat Indian comes. So if we want our newborn children who are in their younger age or in their adolescence, instead of increasing their adiposity or instead of increasing their weight, we should primarily work for increasing their muscle mass. We should work for increasing their length. We should work on their increasing the height, and that will decrease the diabetes risk. If we are going to increase their adiposity, it is going to increase their adiposity and it is going to increase their diabetes. So the life cycle at present, it had become like a vicious cycle. A low birth weight child becoming overweight. This overweight child in a teenage age group develops PCOS and malnutrition. She becomes pregnant with hyperglycemia and pregnancy, again going to give the birth either with a low birth weight or a higher birth weight, which both going to lead with a higher fat percentage. And again, this vicious cycle continue to happen and increasing the risk of diabetes in future generation. So the worm may be more important than home. And this is what the Barker hypothesis, which is first time he told that it's a healthy moms are going to have healthy babies. And that's what the adult disease, which is programmed in fetal or infant life only. And we have to change this program. We have to make our mothers healthy. And that's what we are going to have healthy baby in next generation. These healthy baby, if someone is low birth weight child, they are not only going to have higher risk of cardiovascular disease or diabetes, but they also have higher risk of cardiac as well as respiratory disease too. So the solution for primordial prevention of diabetes in our country, preparing every female child for a healthy motherhood. And this is what we want for our next generation, young who are going to be the next generation, and in their lifetime they should not develop diabetes if we make them healthy, if they are with a normal birth weight and if we can decrease their fat percentage. So what we have to do, as I told you, intervention at every stage we have to do. Like someone with a young who is below the age of 5, we have to promote the breastfeeding, avoid sugar, responsive feeding, controlling screening time, risk assessment, age appropriate physical activity, sleep hygiene, and growth monitoring as per birth weight. If they are school going children, it is 5 to 12 years. Health science school booklet, growth monitoring, healthy diet in school canteen, discourage fast food everywhere, physical activity, promoting sports, and screening for obesity that we have to do for school children going. And here I am very particular to talk about health science booklet because that is going to teach them that what are the things they should do in their lifetime. In a teenager or adolescence, school going, higher school children or the college going, again, they are at higher risk of developing obesity because of their fast food. We have to engage them on a digital health engagement program and a nutrition workshop. The young adults, we have to create a habit of standing habit. We have to incentivize those who are fit, those who are having the fat percentage in their body is less. They should be more, they should be incentivized, and we should create a standing culture in the society. The people who are in middle age, they are at the risk of developing diabetes highest because of their abdominal obesity, where we have to think for decreasing the sarcopenia, because that is also one of the important risk factor for them to develop diabetes. As size, visceral muscle mass is visceral fat is increasing and muscle mass is decreasing. So the nutrition counseling and doing some exercise, which is exercise for muscle strengthening, for abs, for decreasing abdominal fat, that will help them for prevent diabetes or that will help them for preventing cardiovascular disease. Those who are above the age of 65, again, with the health monitoring and preventing the complication, we have to think of preventing sarcopenia for more important muscle strengthening exercise, nutrition. They should not develop osteoporosis, giving them all therapy, and their frailty can be decreased. So, I mean, you improve health of a person at every stage of the life and improve health of every female child. If you want to really primordially prevent the diabetes, we all know the regular risk factor for developing diabetes. It is urbanization, it is unhealthy diet, it is sedentary lifestyle, it is lack of exercise, and it is stress. But if you want to do the primordial prevention, not just primary prevention, we have to work on a maternal health, maternal nutrition, and in utero environment. Because by changing the habits of urbanization, unhealthy diet, or sedentary lifestyle, or improving the exercise, we can prevent obesity, we can prevent conversion of pre-diabetes to diabetes and prevent complication. But if you work on a female children and making them a healthy mom, we can have for the next generation a normal birth weight, a healthy newborn. A healthy newborn will have less insulin resistance, less risk of obesity, and less risk of diabetes too. And with this, we can have a generational impact. So then next generation, we are going to have a person which is normal birth weight, and probably that vicious cycle which I have shown can be reversed completely. For this, we made our honorable president, and we had given that how primordial prevention of diabetes for future generation can be done. And this is what we had given, and she had assured us, and she had connected us to many of the people to whom we can talk, and we had uh, talked about the primordial prevention. And this we have also done in 2017, and there we had given a concept of diabetes free India in 2030 by Honorable President Pranab Mukherjee. And during these 5 to 6 years, we could meet the health department, we could meet the education department. We had tried that NCRT give the health science as a booklet and try to do multiple activities across the country. So the young girls who should be taught maximum, we should invest maximum for these children by counseling them, making them more healthy and physically active. We have to make healthy mom for the next generation to have a normal birth weight child with a less fat percentage. Those who goes to the school kids program, we are doing already. International Diabetic Federation is doing a kids program, making them a healthy youth and making them a diabetes free address. So this is the complete program which we all can do, and we all can join to decrease the incidence and prevalence of diabetes in our country. To conclude my talk, invest in a health of female child, inculcate healthy habits in early childhood, School curriculum, we have to include a health and fitness booklet. A workplace, a sit and standing culture and incentivize healthy habits. Above the age of 45, a regular health checkup and prevent complication. And those who are elderly, prevent sarcopenia. With this, I thank and I say that yes, we can change the natural history of type 2 diabetes. We can close the gates for diabetes. And this we can do if we all work together. Once again, thank you to Diabetes India and to Amit and everyone who are involved here for giving me this opportunity. Recently, we concluded one meeting of World Congress of Diabetes Prevention in our country, where we had talked more about how diabetes can be prevented primordially and how we can do primary prevention of diabetes. Thank you. Thank you once again.
Thank you, Dr. Bansi. Am I audible?
Yes, sir.
Thank you, Dr. Bansi. And I hope you are there for panel discussion. Bansi is there?
I don't think so, sir. I think he's traveling.
Dr. Bansi is in a flight, so will not be available for the panel discussion, but we have a wonderful panel along with you and Dr. Shefali, Dr. Ami, Dr. Archana. So I think we can proceed with the panel discussion, Dr. Bridge.
Okay. Thank you, Dr. Archana, for talking about disparities, what we have in world and what we have in India regarding type 1 diabetes. And you showed us that there is a huge gap, what it should be and what we have right now. We have achieved something, but that is not enough. We need to work more. So what do you suggest that should be done to uplift the life expectancy of type 1 diabetes? What is your suggestion? 1, 2, 3, 4.
So my suggestion, my first suggestion is availability, access to care, availability of insulin, glucometer strips, because it cannot be just insulin. It is insulin, glucometer and strips till the last mile. It is a birthright by our constitution. We have a right to survive. It is not about right to health. So a child dies without insulin and monitoring. Hence, it should have been part of our national program long back. It should have been available at every PHC to every child who has type 1 diabetes, not just a child, everyone who has a person living with type 1 diabetes. So that's the first thing, because the sheer death rate is basically due to lack of basal bolus insulin and glucometer strips to monitor. So that's the first thing. Second, a huge campaign, I feel, of education. Even on our education in college, it was just one chapter of a entire curriculum. We had to I have to study every day and relearn type 1 diabetes. Of course, new things are coming up. That's different, but basics also. So somewhere especially at a government level, because 70% of the children living in the country or people living in the country go to in a smaller towns. It is not the 30% of the tertiary care. So awareness, early detection will happen so a school health program, the way you check everything else, why not also talk about diabetes? Why not tell the symptom? Why not a chapter in the school book? There are so many things that are being taught. If it is part of school health program, then this will happen. So I think two basic things, because we have a beautiful system in the country. We have Anganwadi workers, we have ASHA workers, we have a district hospital network. Only we need to get into it. And two first steps, and I'll not be greedy because I have many lists, but only two first steps is one, education at that level, and second, availability of insulin monitoring strips, and everything else can come later. It is my thought.
So, Dr. Ami, are you there?
Yes, sir. Good evening, sir.
Good evening. What do you suggest regarding diagnosis of type 1 diabetes? What more needs to be done, even at pre-diagnosis level, in that diagnosis? And what if we do antibodies before the actual glycemia develops? Now we can probably prevent type 1 diabetes also from autoimmunity to getting it to getting manifest hyperglycemia. So what do you suggest should be done in that regard?
So first, when we talk about type 1 diabetes, I think Archana madam has beautifully elucidated everything. But sir, the first point of contact in our scenarios is the general physicians. So in fact, I would just cite an example which happened with me yesterday. My father-in-law is a general physician, and he called me up yesterday. And like, I have a 5-year-old kid who has who has infection, burning maturation, and he's passing urine a lot of times. Do you think I should get his sugars checked? So that was the first question. So still, sir, maybe sensitizing the general physicians at that level, because they are the first point of contact, because most of our kids wouldn't go to even a pediatrician first. So sensitizing at the physician level, the GP level, talking about type 1 diabetes, and making them aware that if the patient is coming with polyuria, polydipsia, weight loss, maybe check their blood sugars first. Okay, now this would be my first suggestion in diagnosing type 1. Maybe we are delaying the diagnosis somewhere, and the patient may land up with a diabetic ketoacidosis amongst us, and then maybe life-threatening. Second is, sir, sensitization about the social stigma. Even when the patients come to know, the parents come to know that they have type 1 diabetes, they do not want to start treatment, getting scared about insulin. And let's not talk on a public forum, but we know that people are advocacy is being done that it can be treated without insulin. So that is the second step. Now, the third thing is, sir, what you asked about autoantibodies. Now, whether we need to be checking them. So maybe at our level, maybe, if a patient has any autoimmune disorders, maybe we can check. Or I feel that siblings of type 1 diabetic, they need to be checked, so that because the parents feel it may not happen, but we have seen siblings. I have a family where 3 sisters, out of 3 sisters, 2 have diabetes. So maybe, or even a parent is type 1 diabetic, it cannot be ruled out, and we need to check in their kids also if they have antibodies, or and we need to check for type 1 diabetes. So these would be my points from my end to talking about how we can diagnose type 1 diabetes.
So do you suggest that who are the patients or prospective patients where we should go for autoantibodies?
So as I said, if we have anyone who has any autoimmune disease for type 1, about autoimmune disease, any kid, or as I suggested, siblings, I have seen in siblings. I think Archana madam would be able to help us better there, but I have seen that siblings of type 1, and even because a family which I'm discussing about, the father is a type 1, it has been proved, and then he has got 3 daughters, out of which 2 have type 1. So all are my patients. So we have seen in families also. We cannot completely rule out that it cannot be seen in the families. So maybe that would be the first point of contact when they come to us, and maybe we can ask them to get it checked. But as we know, it can come suddenly, and we may not be absolutely diagnosing every patient, but at least a part of it, if we can diagnose, it would be helpful for our patients.
I totally agree, sir, with Ami, that this siblings would be the choice here. But even there, in our setup, we feel that what will we offer them? Suppose we test. I mean, I'm just being very practical about it. Suppose we test. So today we do have some drugs that can delay the onset. Yes, but still it is just a 2 to 3 years delay. But if it was 100%, yes, it could be a 2 to 3 years delay, maybe from a pre-pubertal to a post-pubertal. It could make a significant difference in the outcome of a child's life. So yes, that is one cohort in Indian setup where a sibling, if we can offer them the treatment as well. I mean, just knowing that you have the potential of type 1 diabetes without offering them a medical therapy, which can help them to delay it, would be a very halfway kind of a thing. That is something we tell all siblings anyway. So I just wanted to share here that One is antibody testing, because what is the global standpoint? The global standpoint is, why do antibody testing in siblings? So that you can delay or prevent the diagnosis with decay, right? That is
Correct.
what they're saying.
Exactly.
But that standpoint can be achieved with good education also. So I'm very happy to say in last 3 years, very unhappy to say that we have many siblings. As Ami said that, I mean, I had at least 40 families with 2 or 3 first degree relatives with type 1 diabetes. But after the first one, all were not detected with decay. They were
Decay.
early detected with the first suspicion where sugar was checked, and very, very early detection, and hence not in decay. So definitely autoantibodies, but if the purpose is that, then even education goes a long way.
So,
That's just
ma'am,
a
if I may
aspect.
take it a little further,
Yes.
I think the first thing that I tell all my whenever I take a meeting is that when a patient comes to you, when even a small child comes to you with fever or whatever, when you're giving an array of tests, just start an RBS.
Yes.
So that itself will give you an idea whether the patient is landing up in some kind of a problem or not, and then you can take it further. So that's a very simple thing that we can say. And even on social media, we all talk about type 2 diabetes, but I hardly see any videos on type 1. So that's something that I think we should be all made aware of.
I think the word all of you use is normalize. If we can normalize it, like
Yes.
Ami talked about the stigma, you're talking about not talking about it. If the normalization happened, I think then we will not get
Yes,
sort of
absolutely.
distracted with all other things. And if you know someone with type 1 diabetes, then you're not distracted with alternative solutions. So just normalization will go a long way in getting good outcomes.
So initial treatment is important, and it should be in non-decay stage.
Yes.
Before the
I believe.
actual decay starts, maybe at antibody level, when it is positive in siblings, that is important, that we should detect at that stage, and probably, quote and unquote, we can offer something to prevent type 1 diabetes at that stage. And we have data as of now that this is going to be a big way if we can prevent type 1 diabetes.
Yes.
Maybe not preventing, delaying the
Yes.
failure. That is important. And then coming about stigma of type 1 diabetes. We have so many celebrities who are herself or himself suffering from type 1 diabetes. And they can help us.
They can, sir, but they don't.
They themselves probably don't
Being
want
very
to
blunt,
publicize
because
that.
I have
Yeah.
tried, begged, borrowed, stealed. It's very difficult even for a cause to get through their agents. It's still a large amount of money involved. Very few people who are just doing it for the cause.
Yes, that
They
is
would like to monetize on this also.
bitter
Yeah.
is what we have to face.
Dr. Briz, they are out of it.
So,
They are,
Hmm.
and they don't do.
Hmm.
And please don't use the word someone is suffering from type 1 diabetes.
Hmm.
Use the person with diabetes.
Yeah.
So this is very important.
Yeah.
Language matters a lot,
yes.
Hmm. True.
particularly when you are talking for type 1 diabetes.
Yes.
So all these celebrities, sir, but
there.
I think it would really help, even if it doesn't have to be a person with a type 1 diabetes. Imagine if
Type
Amitabh Bachchan could do a polio campaign. If
Yes.
Amitabh Bachchan could do a 1-minute campaign on all national networks talking about how type 1 diabetes is not a stigma and children can do great, or talk on KBC about it. So if we had a national campaign with a celebrity, it does not have to be a person living with diabetes. So, but it's not happened. Hopefully one day. Dr. Banshi, that's our next agenda.
Living with type 1 diabetes.
No, but I mean, they don't know. Many of these celebrities to whom you are talking, they are not having type 1. Many of them don't know that what is type 1. You know, first time when we met our health minister, I mean, even we have to teach and educate him also what exactly type 1. So sometimes it's very difficult for people because 99% of the people to whom you see or you meet, they are type 2. And that's the reason they don't understand. Some of them, they consider it's a genetic disease. Some of them, they consider it's lifelong.
Lifestyle disease.
So many problems are there. But if you know someone, you know, I mean, Briz, you are at a place where UP and CM directly approachable. If you can talk to him, I mean, that's something which you can think of. He is a big celebrity, I can tell you, bigger than any film star. So, I mean, anyone, if they can talk from their side, as Archana said very rightly, it will make difference. It will make difference. And this will be our next agenda, definitely. In next type 1 meeting, we are inviting the Deputy Chief Minister of Rajasthan. She herself is a big celebrity also. So, I mean, it will make difference, I'm sure. Okay, bye. I'm sorry, my flight is now taking off, and see you tomorrow. Bye-bye.
Bye.
Thank you, sir.
Thank you, sir.
Bye,
Thank
sir.
you.
Bye.
So should we continue or we had enough of this?
We can have some closing comments, sir. We have 4 minutes. We can talk a little.
Amit, are you there? Amit?
Yes, sir, I am there only.
Okay. So closing
Yes, yes, I was listening to your comments only. So I think we have 3-4 minutes and we can make a summary of what we have presented today. So we know that type 1 care of type 1 diabetes remains a challenge, not only in India, but all across the globe. But advances in the science are now promising. At least now we are talking about the prevention of type 1 diabetes. It may not be accessible and affordable for each and everyone, as Dr. Ashna Sharda has pointed, but at least the science is there. So may not be right now, maybe in near future. I guess these therapies will become more and more affordable and accessible. Each and every person who is detected with type 1 diabetes and those who are at risk of developing type 1 diabetes. So this is a big advancement, you can say, for the science. And for the community, I think in coming time it will happen with the support of all the stakeholders. And excellent presentation again by Dr. Archana, Dr. Bansi, as usual. And all the questions, they have been answered beautifully by our esteemed panelists. And wonderful moderation by Dr. Brish. So what I would say is that it's time now. We can conclude maybe a final comment from all of you, and then we can close the session.
Dr. Archana?
Okay. So I would like to end on a very positive note, on an appeal to anyone who is working in the space of type 1 diabetes, that let's not leave any stone unturned. There are people in this country who are willing to help. Just reach out. There are organizations, there are NGOs, there are CSR funding, there are individuals. If it's a little effort, but one, let's reach out, let's get help for children living with type 1 diabetes. Secondly, let's not give a compromised treatment. For me, saying I give free insulins, and that is something I'm doing great, is a very, I would call it, it's very inadequate. It's very, very inadequate. It's just for me to feel good that I am giving free insulin to people, because free insulin is not a way to make lives better of a child with diabetes. So when we are doing it, we may as well do a comprehensive care. It has to be the whole package of insulin, basal bolus, monitoring, and education. So my thought, and a very strong thought in my heart for every child, is reach out, seek for help. Somebody will help. Give basal bolus, give monitoring, give education, give a comprehensive treatment. That and only that will make a child's life better.
And I would just like to add one more thing, Dr. Ashna here. And it is not just the free insulin. Most of the time, sometimes we feel that we have done our bit by giving free or complimentary consultation from type 1 diabetes. We feel that we are doing some charity or something. I think this should not be our thought.
Exactly.
Even if you are doing it with passion or compassion, you can say, still you have to give the 360-degree solution to the patient, right? This is
and always aspire for the next level. Today you're doing 4 pricks a day. Tomorrow think of 6. Think of SCGMS. Then think of, advanced carb counting. Always keep aspiring to the next level. Do not get disheartened by lack of resources. They will appear. Just go ahead. It's going to happen.
You will find your way once you're there. Dr. Ami?
Yeah. So, sir, I would just end with one note for both type 1 diabetes patient and type 2 diabetes patient, each one reach one. So even if we start talking to our patients, or maybe, they can start talking to others, get your blood sugars checked, any symptom, be it in a child or be it in an adult, they try to just tell कि एक blood sugar करा लो आपका. So even that may, help us to diagnose the huge amount of pre-diabetics which we have, if we can cut down on that load. And I think we all have education programs, we have social media, but I think still a step up, as Archana ma'am says, that, we should not give up, go ahead, keep on educating patients, and education is the key. It's going to take us a long ways.
Absolutely.
Shefali, concluding remarks. What
Everything is said beautifully by ma'am and Ami. But I would like to say that in addition to education, awareness is also a key. Awareness at the level of parents, right from the birth of the child. Probably the neonatologists themselves can start saying that you have to get your child checked up. Every periodic visit to the pediatrician, you can get a blood sugar testing done, which is very easy to do. It's not too much to ask for. So at the level of parents, at the level of school teachers, at the level of peers, because school peers, there are so many children who miss out on their insulin doses because they don't want to show their friends that they have type 1 diabetes. So this, just as blood pressure, dyslipidemia, obesity, body image, everything has been normalized for the Generation Z, I think type 1 diabetes also should be normalized now. That is a very important step that we can achieve. And hopefully the T1D index probably will fare much better than US and China next time.
So thank you everyone for being there with Dr. Amit and Dr. Archana and Dr. Ami, Dr. Shefali. Dr. Reddy, are you there?
Dr. Sanjay Reddy has left because of some work. So I would like to thank all of you for your wonderful presentation. And I would like to conclude by quoting Dr. Chantal Matthew. Those if you were in Delhi in the EASD supported meeting at the ACCD, she said the immunology of diabetes is changing very fast. So it is not just what we used to learn before, and it is the advancement in this field is happening at a very faster pace. And very soon, right now we are talking about prevention of diabetes maybe for a year or 2 or 3, but very soon we may be having therapies which can actually delay it for an even longer period. And there is a dedicated meeting happening on immunology of diabetes in one of the European countries next month. So the field is changing very fast. We must be optimistic, and we hope that things will turn for a change. They will be positive in near future. So thank you very much. And we would like to thank all the delegates, all the participants who have joined us here. And we will see you again tomorrow evening at 8:30 p.m. with the next sessions with the learnings from the EASD. Thank you very much.
Thank you so
Thank
much.
you so much. Thank you so much.
Good night. Thank you.
Bye. Good night.
Good night.